Hello everyone, and welcome to the webinar, Stigmatized Sex, Barriers to Health for Gay, Bisexual, and Other Men Who Have Sex with Men. My name is Rachel McLean, and I work at the Canadian Public Health Association, and I'll be your webinar moderator today. And so before I hand it over to our presenters from the Community-Based Research Center, I have just a few housekeeping items to go over. So as I mentioned, this webinar is being offered by the Canadian Public Health Association as part of a webinar series that we'll be hosting over the next several months focused on the reduction of stigma associated with sexually transmitted and bloodborne infections, as well as sexuality and substance use more broadly. So more information on this webinar series can be found on CPHA's website at the link provided on your screen. And you can also connect with me if you'd like further information on the webinar series. We've already hosted a number of sessions, and so the recordings are also made available on CPHA's YouTube channel. So hopefully at this point you can all hear me through either a headset or the speakers on your computer. Due just to the number of participants, we have disabled everyone's microphone for today's session. That said, we'll certainly have some time at the end of the session for questions. We simply ask that you use the chat box to the right of your screen to pose your questions to today's presenters. And so during today's webinar, the presenters will be discussing some of their work and some of their research related to some of the barriers to health for gay, bisexual, and other men who have sex with men. And so, but as I said, we will have about 10 minutes at the end for Q&A. And then before we begin, just a quick note to say that today's session will be recorded, and as with our other webinar sessions, it will be made available on CPHA's YouTube channel. So today we are going to hear from Michael Kwag, Darren Ho, and Kirk Furlotte. So I'm going to provide you with a brief bio for each of our presenters, and then I'll hand it over to them. So beginning with Michael Kwag. So Michael is the Director of Knowledge Exchange and Policy Development at the Community-Based Research Center. He began his career in gay men's health in 2004 in Vancouver, coordinating CBRC's Totally Outright Youth Leadership Program, before moving on to a variety of community-based research and health promotion roles in both Vancouver and Toronto. In 2017, Michael returned to CBRC to lead the development of the Advanced Community Alliance, a 5-year initiative in partnership with Health Initiative for Men, the AIDS Committee of Toronto, Max Ottawa, and RAISO to increase health service access and uptake among gay, bi, trans, two-spirit, and queer men in Canada. Michael's current portfolio includes the Summit, CBRC's annual Knowledge Exchange and Capacity Building Conference on GBTQ health, Mobilizing Sex Now research finding, CBRC's periodic nationwide GBT2Q survey, and policy development and engagement activities to facilitate provincial and federal support to GBT2Q health. Next up is Darren. So Darren Ho is the Program Manager of the GBMSM Health Network. He has been working, volunteering, and immersing himself in gay men's health since 2011. Currently, his work involves building and maintaining a network of folks who work in gay men's health and HIV in British Columbia. Darren's experience in HIV prevention comes from his past of coordinating educational and social opportunities for gay, bisexual, and queer youth across BC. He is dedicated to the work involved in ending HIV stigma in our communities and strives to build stronger communities for gay men. And then last, but certainly not least, we have Kirk Furlotte. So Kirk holds a Master of Arts in Health Promotion from Dalhousie University, where he completed his thesis looking at perceptions of end of life of older GBMSM. He has worked in queer and trans health research and advocacy through a number of Halifax organizations. As the regional manager for CBRC in Atlantic Canada, he seeks to increase access and uptake of combination prevention strategies related to HIV and STBBIs. Kirk's work involves collaborating with community-based organizations, service providers, and key stakeholders. Kirk continues his research through projects on advanced care planning and long-term care needs for older LGBTQI2S+ adults. And so with that, I'm going to hand it over to our presenters from CBRC.
Great, thank you, Rachel. I'm going to take it from here. Hi, everyone. This is Darren Ho, And if you need to visualize me as you listen to me, on this slide I am the one pictured on the very left in the blue shirt and yellow background. Um, so I'll start by first explaining what is the Community-Based Research Center and what it is that we do here at CBRC. Incorporated in 1999, CBRC is a nonprofit charitable organization that promotes the health of gay men through research and intervention development. We are inclusive of bisexual and queer men, cis and trans, and two-spirit people. Our core pillars, which are community-led research, knowledge exchange, network building, and leadership development, position the organization as a thought leader, transforming ideas into actions that make a difference in our communities. We are a national organization that works on influencing and changing the policies and structural components that will result in better health outcomes for LGBTQ men, that's gay, bisexual, trans, two-spirit, and queer men. As a pan-Canadian organization, CBRC acknowledges and respects that we work on the traditional and unceded territories of First Nation, Inuit, and Métis peoples and communities. We recognize and appreciate ancestral and continued ties to the lands and waters since time immemorial. With that, I'm going to pass it over to Michael Kwag.
Kirk.
Oh, Kirk.
Yeah, sorry. Hi, everyone. This is Kirk. We've divided our content into 3 areas based on our objectives. In just a moment, Michael will take over and speak to the underlying structural and systemic determinants of GBMSM health. I'll then step back in and talk about the ways that you and others can help identify methods to eliminate some of the barriers to equitable healthcare for GBMSM. I'll hand things over to Darren, who will talk about ways to provide better healthcare to GBMSM, starting with a personal story and then some practical tips. Michael will then wrap things up before we move into the Q&A portion of our session. Before we begin, I would like to talk about the language we use and why that matters. We recognize the importance of language and how much language matters in lived experiences. Our decisions about language should be made with intention, but we can't guarantee that we will always capture the broad scope of men's experiences. Much of what we know about GBMSM health has developed from lived experiences and research data from men who primarily identify as cisgender and gay. Although some samples include bisexual, queer, two-spirit, and transgender men, in most cases there are small numbers of men from these groups included in research. So if you're doing research, please be sure to consider these men. We at CBRC are moving towards using more inclusive language. Check out our social media for our current community consultation on language use. Language carries cultural significance and often reflects the social environments in which we live, and it is something that must be self-determined. One of the best ways to engage and build rapport with patients or clients, particularly GBMSM, is to adapt your medical language to fit your patient needs. So who are GBMSM, and why are we using that term? Our goal is not to eliminate identities, but to try and be inclusive. We're using GBMSM as an umbrella term for multiple identities with the recognition that they can't capture everyone. Simply using the clinical term of MSM medicalizes and disregards the intimacy between men. Yet we know there are men in relationships with men that don't identify with labels like gay, bi, queer, or two-spirit. And men are more than just their sexuality, which brings us to intersectionality. Very few GBMSM across North America are white, cis, rich, or conventionally attractive men, and we all face different kinds of oppression. Our intersecting identities are fascinating and beautiful, but they also make for complex and layered oppressions that make it exceptionally difficult for some of us to navigate the world, let alone healthcare. So with that groundwork laid, I'm now going to turn things over to Michael Kwag.
Great, thanks so much, Kirk. So in this first section, we will review the key determinants of health affecting gay, bisexual, and other men or sex with men. Our goal here is just to summarize some of the negative health outcomes faced by GBMSM, at least at a population level, and then consider different factors which shape the health of these GBMSM, including why in some cases GBMSM may experience negative health outcomes, and other times able to persevere and achieve positive health outcomes. It really is just a brief introduction to some key issues and theoretical approaches within this area of research. For those who are interested in learning more, I definitely suggest looking up the Institute of Medicine's report on LGBT health from the US a few years back. Okay, so why GBMSM? So a common question that arises when speaking about GBMSM or even LGBT health is why is this still an issue given that the community has seen so many gains in terms of civil and human rights, biomedical advances, cultural change, as reflected by the significant increase in representation of queer people in entertainment, in politics, and in the economy. Decriminalization and delisting of homosexuality as a mental disorder, same-sex marriage and protections from discrimination, all of these are important achievements that have been important social justice and equality milestones for gay, bi, queer men, as well as preconditions for their improved health. In the context of HIV and AIDS, we've witnessed transformational change in treatment effectiveness since highly effective antiretroviral therapy became available as early as 1996. These biomedical advances have not only transformed HIV from a death sentence to a chronic health condition, but have also made HIV treatable to the point where someone receiving effective treatment can reach undetectable levels of the virus, making sexual transmission effectively impossible. This is supported by undeniable scientific evidence through robust international clinical trials, which have found 0 cases of transmission in the tens of thousands of serodiscordant couples that have participated in these studies. Also on the prevention side, biomedical research has also led to the development of PEP, or post-exposure prophylaxis, and PrEP, or pre-exposure prophylaxis, both of which are highly effective tools for HIV-negative individuals to prevent HIV. Due to time, I'm not really going to be getting into these much further, but can happily say now that there are some very good educational or informational resources on both PrEP and PEP in Canada and around the world. The key point here is that the treatment and prevention landscape for HIV has changed remarkably due to biomedical advances. But even with these game-changing tools, we still see stable rates of HIV among GBMSM and other key affected populations, which I'll get into a little bit later. So just a bit of a quick overview in terms of GBMSM health outcomes. And one thing that's important to keep in mind is that much of the progress that I referred to in the last slide is still relatively recent in historical terms, and that the process of cultural change can be more complex and uneven than one might expect. The evidence on negative health outcomes among GBMSM and other members of the LGBTQ community is quite expansive. It paints a concerning picture of negative health and social outcomes at a population level. Research studies have demonstrated highly elevated rates of depression, anxiety, and suicidality, including that 33% of lesbian, gay, and bisexual youth attempt suicide, a stat that's even higher among trans youth, as well as 2 to 4 times higher rates for smoking, substance use, and addictions. Findings from CBRC's Sex Now survey and many other community-based studies show that GBMSM are still reporting lots of homophobia, experiences of harassment, discrimination, and violence, whether that's in schools, in the workplace, within the home, and even within healthcare settings. We know that these experiences of being stigmatized and marginalized can lead to things like trauma and shame, increasing the likelihood of unhealthy coping practices, and at the same time reducing the likelihood of those people accessing supports, including healthcare services. So it's time for just a quick poll, and the question that's being posed is minority stress is experienced in the same way by all stigmatized groups. And so it's a true or false or I don't know question. So we'll just take a minute to let people vote in the poll. Okay, so I see that the results are trickling in. Maybe we'll just see if there's a couple last minute votes coming in. So 21 out of 29, that's basically most of the participants on the call. So I'll just say that the answer to that question is false. So congrats to the 22 of 23 who answered false to that question. And I think just given that most people answered that as false, this is encouraging because definitely one point that sometimes kind of gets glossed over is the fact that the way that minority stress and stigma is experienced is the same. It's actually not, and kind of goes back to the points that Kirk was raising when talking about intersectionality earlier in the presentation. So minority stress is a very important theoretical approach to understanding not only the health of gay, bi, queer men, but that of also other marginalized communities. The key idea in minority stress is that members of minority groups face the same everyday stressors and challenges as folks who are not members of minority groups. But on top of that, all of the stressors and challenges that stem from being a member of a group that is stigmatized for one reason or another. So this could be experienced at a direct interpersonal level, reflected by concrete experiences of prejudice or discrimination. But it can also be a little bit less direct or proximate, such as the kind of stress that could result from living in a city or country that has stigmatizing policies towards your community or population. I don't know, maybe a ban on blood donation for those that are gay, bi, or have sex with men. These kinds of minority stressors can lead to unhealthy coping strategies or practices, and for GBMSM, this might mean having to, or feel like having to conceal their sexuality or identity, which produces more stress, as well as things like internalized homophobia and a negative self-worth related to one's sexuality. And I think one last thing to note is that clinical studies have actually shown that minority individuals, not just gay, bi, queer men, but including them, experience a high degree of prejudice, which causes physiological stress responses, whether that's reflected by high blood pressure or anxiety. And these physiological stressors accrue over time, eventually leading to poor mental and physical health outcomes. Sorry, I'm just having some issues with the slide. Sorry. Okay, so we're down to our next poll question. Question is, are you familiar with the concept of syndemics? Yes, no, or somewhat. So we'll take a minute just to put in your votes. Okay, it looks like most folks have submitted their votes, and unlike the first question, there's quite a bit of diversity in terms of responses. So I think that's good. So we'll kind of jump right in and start unpacking this. So essentially, syndemics is sort of defined as a cluster of epidemics that act additively to predict other epidemics. So the key takeaway around syndemics is that when considering a health issue like the high prevalence of HIV or substance use or even suicide and suicidality among GBMSM, you really need to consider what's going on at a broader health determinant level. and consider the interconnections between different health outcomes. So as referenced earlier, the research on the health of GBMSM has documented each of those health issues pretty solidly, whether that's around HIV, substance use, or poor mental health. Research around syndemics has provided insights as to how and why the HIV epidemic among GBMSM needs to be considered alongside other significant co-occurring health issues like depression, substance use, and/or experiences of victimization through partner violence or childhood abuse. Rather than being random social phenomena, this research helps us to appreciate how these health issues and experiences of victimization are interconnected with each other and actually interact to drive risk and vulnerability to things like HIV. The important thing to remember is that progress on fighting any one of these specific epidemics, so HIV or mental health issues or substance use, the progress on fighting any one of these epidemics is likely to be limited by the lack of attention and progress on other health issues. So a narrow focus on reducing reducing HIV risk behaviors or problematic substance use without addressing the factors that lead to those risk behaviors taking place in the first place may be insufficient. On the flip side of that, it also means that when we broaden our health promotion approach and strategies to support the broader health determinants like access to social support and health services, we may be able to have a more sustained and effective impact. Sorry, Darren or Kirk, can you flip the slide down? Thanks. Okay, so I've already made reference to the issue of HIV among GBMSM, but just want to review a few key stats which are based on the Public Health Agency of Canada's most recent population estimates from 2016. As has been the case since the onset of the epidemic, HIV continues to disproportionately affect GBMSM more than any other population in Canada, and and this is also the case in many other countries around the world. Representing just 2 to 3% of the population in Canada, they represented 55.5% of all new HIV infections. Based on these latest surveillance data, GBMSM are estimated to be 131 times more likely to become HIV positive than men who do not have sex with men. Thanks. So why is HIV so prevalent among GBMSM, especially in light of the biomedical advances that were referenced earlier? One thing that I think is important to kind of keep in mind is that there are some pretty important and often undiscussed reasons for this high prevalence and incidence of HIV among GBMSM. And these factors are in some cases grounded in basic biology and the physiology of gay sex, while others point to the role of social environments in the lives of GBMSM, namely sex education or the lack thereof within schools and the stigma that GBMSM may experience within the family, at work, or also within peer networks. I won't go through each one, but I think it's just important to appreciate that there are some often complex factors that are at play, which may be unique and specific to gay, bi, queer, and other men who have sex with men, and that may help to explain sort of what's going on there. I think one last point that I wanted to make around that slide was just that health promotion efforts should continue to work with gay men in light of these factors in ways that embrace rather than shame the risk taking and seek to build communities and environments that minimize structural risks such as criminalization of HIV non-disclosure and addressing things like institutional racism. Having more holistic approaches to supporting GBMSM around the risk that's present in their lives will actually help to strengthen their health and well-being across the board. And so this slide, I mentioned earlier that I think the research around GBMSM health is often sort of focused on sort of risk factors and all of the negative health outcomes that some GBMSM experience, whether that's around HIV or substance use or mental health. I think it's important to note that the research also is documenting different protective factors, things that may lead some GBMSM to somehow, in the face of all the stigma and stressors that they experience in their everyday lives, are able to sort of maintain positive health. And so there's a growing body of research that looks into the different factors and different interventions that can be sort of used to support GBMSM in supporting their overall health. And so that includes things like family connectedness, teacher caring, and other adult caring. This is, of course, research that's coming out of schools and LGBT youth. Also things like GBMSM sense of coherence with regard to their sexuality and other aspects of their social identity, looking at things like social support and their self-advocacy and sort of ability to or capacity for health literacy. So I know I'm sort of going a little bit over time, so I want to pass it off to Kirk to get into some of this.
Thank you, Michael.
A little bit deeper.
So if we were to talk about eliminating barriers, let us first turn our attention to identifying barriers. GBMSM don't always tell their healthcare providers the whole story. I'm sure for many of you that's no surprise. However, it's often related to the minority stress that Michael's mentioned and past negative healthcare experiences. So if you don't know what your patient or client is doing, how can you properly counsel them? When GBMSM do open up, they often find healthcare providers who are not equipped to meet their needs or address their health holistically. While it's great that many people want to follow the golden rule and treat everyone the way that they would like to be treated, we might have very different lived experiences and specific health needs. Finally, I'll say that healthcare providers who do make an active effort to find the language and the answers for their GBMSM patients or clients create better relationships and better health outcomes for those clients. One common refrain that we hear is, but I don't have many or any gay patients. So this case study stems from work that CBRC has done with partners in northern British Columbia. The BC Centre for Disease Control estimates that there are approximately 2,200 men who have sex with men living in the Northern Health Region Authority, but acknowledge it could be over 3,000. In our Sex Now survey, which is, as mentioned before, our recurring quote-unquote gay census, almost 60% of the men who have sex with men identified as gay. You can also see some of their health practices and risk. Almost 1/4 had never been tested for HIV, and half had never heard of PrEP or PEP. The bottom line is if GBMSM are not out to the provider, they're up to 10 times less likely to be tested for HIV, and 60% of those men are not, the men in this region are not out to their provider. So don't assume that just because a client or patient hasn't outed themselves doesn't mean that there aren't GBMSM accessing your services. And I'd also like to point out that of the men who have sex with men, 6% did identify straight. So now it's time for another question. This is a fill in the blank. So blank is the belief that heterosexuality is the norm or default sexual orientation. Your three options are heteronormativity, homophobia, and cisgenderism. Well, I feel like we're preaching to the converted here. All right, so 100% of respondents have said heteronormativity, and that is, of course, the correct answer. So we're going to delve into that on our next slide. Heteronormativity is based on the idea of the gender binary as well, that there are men and women only, which I hope we all know isn't the case. Heteronormativity assumes that relationships are really only ever going to be between two people of the opposite sex, which leads to heterosexism, the system of norms, ideas, values, and attitudes that implicitly, and sometimes explicitly, assume heterosexual superiority. This creates advantages for heterosexual people and disadvantages for everyone else, and leads to structural inequities that impact GBMSM. The next step in the equation is homophobia and biphobia. It's not just fear, it's hatred of things and people that are perceived to be quote-unquote gay. The reality is that we are bombarded with heterosexist and heteronormative concepts without always recognizing it. It's a series of events that lead to GBMSM often feeling like they don't quite belong. For example, when a cab driver asks me if I'm dating a nice girl, I don't always correct them because I don't want to risk being kicked out of a cab, which in 2019 still happens. And I promised we'd talk about the determinants of health, and as someone with an undergrad and master's degree in health promotion, how could I not bring them up? So, quick question. Of the following, which determinants of health influence the health of GBMSM? We have a number of options here. Income and social status, race, HIV status, healthy child development, or all of the above. And the answer, of course, as 21 of you have said so far, all of them, and maybe some determinants that don't even make it to most lists. Thank you, everyone. Let's start with the simple acknowledgement that the determinants of health impact all of us in different ways. Now, how is it different for GBMSM? Well, it can vary greatly. Let's talk about physical and social environments. Do GBMSM feel safe? Are they actually safe from harm? Social support networks. Michael highlighted this is a protective factor, but if someone doesn't have that, how might our health issues be exacerbated? How can we expect GBMSM to develop the best personal health practices when their needs and issues aren't taught in schools? And their parents most definitely don't know what to tell them. I mean, my parents sure had no idea how to have the sex talk with me after I came out. And being out itself can be a determinant of health for GBMSM. Being out can liberate someone to seek the services they need and find their community, but it can also put them at risk of harm depending on where and when they come out. So the when is a factor I'd like to talk about next. We're going to talk about age as a determinant and how it impacts GBMSM. Life course models help you to account for cumulative lived experiences and tailor care, support, and prevention to meet someone's needs. This is pretty basic. I'm just going to hit the key points here. The three key elements are historical time and place, recognizing that someone's understanding is tied to their historical setting in which they develop. Their linked lives, that lives are lived interdependently, and social and historical influences are expressed in our network of shared relationships. And finally, human agency, that people construct their own life course through choices and actions, but within the opportunities and constraints of their time and circumstances. CBRC has done a bit of our own work in this regard, and we have 5 generations of GBMSM for you to consider. Again, this is just a quick snapshot, but some of the key points are the stigma generation, who were born in the 1930s, and they saw gay identity transforming from a mental illness to a legitimate social identity. The Stonewall generation was born in the 1940s, and they were the first generation to experience gay liberation in late adolescence and early adulthood. Both the Stonewall and Stigma generation witnessed the devastation of the AIDS epidemic firsthand and experienced profound setbacks to gay liberation and challenges in creating community. The first AIDS generation were born in the 1950s and 60s. We found that they were probably hardest hit by AIDS as it struck when they were at the peak of their sexually active lives. For this generation, one of the quotes was that it was almost a war zone, with outwardly healthy and attractive men in their 20s and 30s falling ill and dying in a matter of weeks. The second AIDS generation were born in the 1970s. This is my generation. We grew up at a time when AIDS was conflated with gay sex, disease, and death. But I haven't experienced the same degree of personal loss that the first AIDS generation did. We were more aware of risks and safer sex practices. My generation saw the evolution of HIV and AIDS to a chronic manageable condition, and discourse has shifted to focus more on issues such as marriage equality and human rights. The post-AIDS or marriage equality generation were born in the 1980s and 1990s. They grew up under very different social and political contexts than all previous generations. As one participant put it, they're the first generation to now experience their same-sex desires absent the same fear of AIDS that consumed members of my generation when we were beginning to have sex. Having worked with many queer youth, they also take it for granted that they have rights, whereas previous generations understood the challenge, might have a more lived experience in the battle to earn those rights. We haven't named the generation of those born in the aughts yet, though I'll advocate for the Tumblr generation when it comes time to do so. If you'd like to learn more, you can get the Gay Generations document on our website in both official languages. My final point, we don't just pass through these ages and stages, we actually construct those ages and stages. We, as GBMSM, are making our own communities and cultures, and sometimes we even have to create our own services. But ideally, healthcare organizations and service providers can work with us to provide better care, which is how I'm going to segue over to Darren, who will talk about defining practices to provide better healthcare to GBMSM.
Great, thank you so much, Kirk. So from here, as Kirk said, I'll take us through some slides on practices to provide better healthcare for GBMSM. And I want to start with a story about myself. So for this story, I'll have everyone imagine or try to imagine me as an 18-year-old, which for context is over 10 years ago because now I'm 30 years old. So the story takes place with me growing up in Coquitlam, which is a city that's not too far from Vancouver. I had just had my first sexual experience with another boy. So I went to my family doctor the day after because at that time I hadn't learned anything yet about window periods and thought that I had to get tested for STIs right away. So I went to my family doctor, I told him I had sex with a boy, and his response, that I still remember to this day, was 2 questions. First question was, did I use a condom? So the answer was yes, but because the condom broke, I answered no. So no, I didn't use a condom. The second question was, do my parents know? And so it wasn't like, do my parents know that I'm gay, or do my parents know that I'm having sex with a boy, or do my parents know that I'm coming to this doctor visit? It was just, do your parents know? So the answer was no, of course not. And it would be almost 10 years later before I tell them that I was having sex with boys. So both questions he asked me, I still remember to this day, were in a very accusatory way. And I still remember the tone of his voice and how he lectured me with, you should always use a condom. And so I thought it was weird that he asked me if my parents knew. And thinking about it now, I know that he might have just been asking me to see if I had a support network at home about being gay. But back then, as an 18-year-old, I didn't really understand why this question was being asked. And so I assumed that if I had told him anything else, that he might tell my parents, because he was also the doctor for everyone else in my family. And so that time that I had with my doctor was the last time I visited my family doctor. And since then, I had only gone to checkups at walk-in clinics or sexual health clinics. Luckily, I live in Vancouver, where we do have gay men's health clinics for me to access. So this doctor has now since retired, and I now have a new family GP only as of a couple of months ago. So my point here is that one interaction was all it took to turn me off from not seeing my family doctor again for over 10 years. So again, this happened when I was 18. I'm 30 years old now, and I just got a new family doctor a few months ago. So with that story in mind, I want to delve into how healthcare practitioners can improve their care for GBMSM. But first, the question, and this question is, do you know people in your field who are uncomfortable working with gay, bisexual, and other men who have sex with men? And as you submit your answer, you can keep in mind that we can't see individual responses, so this is anonymous. Do you know people in your field who are uncomfortable working with GBMSM? Okay, so I see that I'm getting a mix of responses. Most people have answered yes, and some people no, and some people maybe, which is a good place for me to start to know as I delve into my next couple of slides. So here are just some quick notes as a backgrounder to working with GBMSM. One is that most people receive little education about gender and sexual diversity. So it's definitely okay to ask questions and definitely okay to not have the answers to everything all the time. Speaking about gender variance and any kind of sexuality is uncomfortable for many. So this is true for straight and gay, cis and trans, men and women. So again, it's okay to take some more considerations when delving into these topics. Individual sexual orientation and gender identity should be defined by the person, not the provider. This point might seem obvious, but it's worth reminding folks to not label someone unless they've chosen that label for themselves. If a patient that you're working with has been talking to you about how he has had sex with men, it's still not okay to start asking him questions about being gay, as that might not be how he identifies. Mental health issues from minority stress impact sexual behavior. So we have talked about minority stress earlier, and it's good to keep in mind that this is a factor in the sexual behaviors and decisions that GBMSM make and do. And finally, primary care should be accessible and relevant to all persons, including GBMSM and other marginalized populations. As a healthcare provider, what you know and how you talk about things like risk matters. So challenging HIV and sexual stigma matters. And we see that in the way that healthcare providers communicate with their patients. When it comes to HIV prevention tools, it's not enough just to say to use condoms every time. Now is a good time for all healthcare providers to brush up on PrEP, pre-exposure prophylaxis, because gay and bisexual men are learning about this prevention tool from their peers and on dating apps. So as Michael mentioned, there's a lot of great resources online now to learn about pre-exposure prophylaxis. Talking about testing and knowing the status of our partners as an HIV prevention strategy is also very impactful. And when it comes to asset-based versus deficit-based language, it can be as simple as asking, what are the steps you're taking to stay healthy versus what are you doing to avoid an STI or an HIV transmission. And of course, having a sex-positive attitude when communicating with GBMSM is important, as well as talking about HIV in ways that are not stigmatizing to people living with HIV. But we know that even those with the best intentions sometimes get it wrong. Take this ad campaign, for example. This is a One Life campaign, which is meant to communicate the message to get tested for HIV, which is a great message. But the tagline is also very stigmatizing. It reads, "Each time you sleep with someone, you also sleep with his past," which when combined with this imagery, or especially when combined with this imagery, does a good job at implying that your partner is promiscuous and doesn't get tested himself, which is not a very sex-positive message. So here are some examples of how to tread on the fine line between treating GBMSM just like everyone else, also while having the competency about our experiences to know when to adjust your language when needed. For example, do you have sex with men, women, or both is a way to be inclusive of bisexual men. Using general terms like partner for gender neutrality is always a good idea. And challenging our heteronormative views that marriage does not mean monogamous and sexual orientation is not the same as sexual activity is also good to keep in mind. And also not assuming that condoms or lack thereof means safe sex or unprotected sex, as some guys may be using condoms along with other preventative tools like PrEP. This here, I feel this is an important resource. This picture on the right here is just one part of a larger document that's a very helpful tool for educators and physicians on language to use that is inclusive and destigmatizing. So you can access this resource on pacificaidsnetwork.org. I think if you're watching this webinar live, you can click on the what's on the screen, the link there. But if you're watching recording of this, you can follow the link on the slide itself. YouthCo developed this resource, which is now on pacificagenetwork.org. YouthCo HIV and Hep C Society is a Vancouver-based nonprofit organization run by and for youth. So they do a lot of work around HIV education, prevention, and support within an anti-oppressive framework. So they take inclusive language very seriously. As you can see in the first point, even the small difference of using the word path instead of infect or spread can make a difference when talking about STIs, since infect or spread come with some negative connotations. So I won't go through all of these points here, but you can access the full version of this document using the link on this slide. And finally, a note about safe space or safer space. There might be the assumption that LGBT people can be spotted. However, we know that many are not identifiable. People need safe opportunities to disclose and safer spaces to be out. So besides using inclusive language, having identifiable LGBTQ2S staff and signage and reading materials may make it easier for clients to be out. I also believe that you can kill two birds with one stone with health promotion by putting up health promotion posters that feature LGBTQ people in them. If you are lucky to have a gay men's health organization in your city, you can contact them for some posters, as I'm sure that they'll have lots, or an AIDS service organization, for example. So I'll just reiterate here a quote that a healthcare professional in Vancouver said. It's not enough to know in your own head and say, oh, I'm okay with it. You've got to indicate that to me, because I've been through so much homophobia that I'm not going to take it for granted that you're okay with me. I still don't assume that people are okay with me or with us. And with that, I'm going to pass it back to Michael.
Great. Thanks so much, Darren. And thank you, Kirk. We hope that this presentation has been useful in terms of introducing some helpful concepts, some research, and some ideas around how we can all sort of be more inclusive and be more aware of different health issues faced by gay, bisexual, and other men of sex with men. Just one last thing, and we're a little bit later than what we'd hoped to, and we just want to make sure that there's a bit of time for some questions. I just wanted to make a couple last points just around the importance of community leadership in terms of health promotion for gay, bi, and other men of sex with men, but also the importance of community-led interventions and strategies and approaches in terms of addressing things like HIV and STBBIs more meaningfully. So at Community-Based Research Center, we are an organization by and for gay men, and part of that means considering that gay men and other men of sex with men are leaders in preventing HIV. Over sort of the course of the epidemic, gay men have demonstrated their leadership and their ability to adapt to the risks posed by the HIV epidemic. So that might include things like strategic positioning, where gay men of opposite serostatus, HIV positive and HIV negative, have sex. We might consider that there's less risk for the inserted partner to be passed compared to the partner who bottoms. Serosorting, condom use, regular testing, these are all examples of ways that gay men have taken different tools and used their knowledge around how HIV was being passed around in the community and developed some community-led sort of solutions and ways of addressing the epidemic. And then, of course, things like highly effective antiretroviral treatment, which we are sort of now kind of referring to as treatment as prevention, or U equals U, which stands for undetectable equals untransmittable. And I think the key point here is just recognizing that gay men have been sort of at the cutting edge in terms of HIV prevention, staying on top of different developments within the scientific and biomedical fields, and being the first to adopt these tools and strategies. This last slide, it just includes some logos from different initiatives, interventions that CBRC has been leading over the years. Totally Outright is an intervention that CBRC first piloted back in 2005. It's a sexual health leadership program that addresses sort of knowledge gaps and capacity building around HIV and STD-VI prevention, but also around equipping young men with different leadership skills to become peer leaders, and also sort of actively involved in health promotion for the broader community. Investigators is a research-based intervention that CBRC has been developing as kind of an offshoot from Totally Outright, really an intervention to support guys who've gone through programs like Totally Outright and equip them with skills to critically examine the research that is used to describe GBMSM health, and giving them the skills and opportunity and mentorship to kind of take on different research studies themselves. And Pivot is our new adult intervention. Similar to Totally Outright, we'll be kind of supporting local GBMSM to learn about social and structural factors that shape GBMSM health, and to get involved by addressing a local community health issues or priority. And Resist Stigma is a campaign, a youth campaign that CBRC led a few years ago that basically organized youth leaders across the country in developing their own stigma projects to address different local health priorities. So I just wanted to speak to that, because I think this kind of intervention sometimes gets lost when considering all the different tools that exist biomedically speaking. It's certainly a type of intervention that we prioritize at Community-Based Research Center, given our sort of values around community-led participation in HIV prevention, but also health promotion, and giving guys different tools and opportunities to become more meaningfully involved in this work. Last slide, I just want to thank everyone for taking the time to join in on this webinar. Our contact info is listed in case you're interested in more information, or if you're interested in collaborating with us. Please visit our website, cbrc.net, like us on Facebook, follow us on Twitter, and a special thank you to our funders and donors whose essential support allows CBRC to do its work, in particular the Public Health Agency of Canada and the Provincial Health Services Authority in BC.
Great, so thank you so much, Michael, Darren, and Kirk, for that very informative presentation. We do have just over 5 minutes for questions. So at this time, I invite all of our participants to use the chat box to the right of your screen to pose some of your questions. I do see some comments. Jacqueline, I see that you're saying all GPs need to hear this talk. As I mentioned, we'll be making this available on CPHA's YouTube channel, and so if you have means through which you can share it with other health and social service providers, we would encourage you to do so. And there's also a question about getting a sticker for the office indicating that it is a safe place for all people. So I see that Kirk is also providing some links, and Lynette has as well. So yeah, if you have any other questions, please use the chat function there. So as folks are taking a little bit of time just to perhaps pose some questions, I just want to put in a plug for our next webinar. It is scheduled for March 21st from 1 to 2 Eastern Time, and it'll be focusing on the effect of public health policies on stigma and innovations in HIV case management nursing. So the link will be made available to register in the coming days with that link provided there on CPHA's CPHA's website. And then we'll also have a post-webinar evaluation survey. We just ask you to take some time to fill that out. The results will be shared with our 3 presenters, and it'll really just help us improve future webinars. Again, I mentioned the recording will be made available, so that's the link to CPHA's YouTube channel. It'll likely be put there within the next week or so, but you can find other webinar recordings focused on reducing stigma related to STBIs and sexuality and substance use there as well. That is my contact information. If you have any questions for our presenters and you didn't get a chance to kind of write down their contact information, you can also send your questions to me, and I'll make sure that I put you in contact with Michael, Darren, and Kirk. Or if you have some questions just related to some of CPHA's work or our webinar series, you can also get in contact with me.